I'm going to talk about Presbyond, blended vision. It's based on optical aberrations. The concept is key here for this technique, so that's why I'm going to be continuously referring to optical aberration. Traditional mono vision apparently is still an acceptable, valid technique, but as of 1.5's prescription modified mono vision, exceeds the traditional one, so with the aberrometry is less, and that's as of 1.5 prescriptions. Presbyond has 6 key elements. That's the mechanisms of action. It increases the field depth. It modifies the spherical aberration. It creates a slight myopia in the non-dominant eye. It favors pseudo-accommodation thanks to a spherical aberration. It has a combined vision area, blended vision, then cortical processing, then neuroadaptation, which is key. Important to do the right examination. Without the right examination, we won't succeed. Key to understand binocularity, the proximal convergence point. We need to study the pupil dynamic, the accommodation amplitude, dominance test, motor sensorial, and we need to take a look at all the tests to see who's a candidate, to see who we can operate on, who we cannot. Changes in the SA, it's based on accommodation. The changes will go to a negative aberration, and that we need to do. We also know that when we diminish the pupil size, then the spherical aberrations that are negative create a myopic effect, and vice versa. And we need to understand that a hyperopic patient with a presbyopia operation, then negative spherical aberration, then we have the meiosis, the close convergence to the refractive change toward myopia. That's why the people with the presbyopia, hyperopia that have been intervened undergo this myopization, and they do better. And it's the opposite with a hyperopic patient. With a myopic patient, a positive spherical aberration changes, and then they do a hyperopization, and they do poorly because we need a greater refocus, and that they tolerate worse these surgeries. Criteria related to the quality of the image. This out of focus may be perceptible, may be problematic, may be not acceptable. So it's unacceptable if they can objectify things. There are margins, so non-acceptable. The focus minus, plus 0.3, minus 0.4. And spherical aberration, that's the change. That's the change. Plus 0 to 50. This is the change. That's the degree of tolerance. Presbyopic patients. Plus minus 0.37 and 52. That's the range. That's the key, because if we go beyond that, we will not tolerate it. The eye will not tolerate it. So traditional monovision, what does it do? There's a blurred vision area, whereas with Presbyond laser by Zeiss, what we do is this blurry intermediate vision, we substitute it, because we will never go beyond this tolerance, minus 0.56 microns. That's why it's called blended vision, blended zone. And that's also for myopia, for hyperopia. The techniques, these techniques are better than traditional monovision. That's the effect of the aberration. It's always less than defocus, because defocus creates more blurred vision, that aberrometric changes, the same situation. So that's the area that we will be working on. Positive aberration in the cornea, 0.20, 0.25, more or less. That's our action zone as of a certain age, with a length that's there's a PNS2 cataract, then it's a different surgery. So in a low myopia case, we increase the spherical aberration, SA, and with high myopia, the SA will go over the threshold, and the Presbyond brings it back, brings it low, never more than 0.56. If there's high SA, then it's the same. The technique lowers it. That's as far as myopia goes. That's the maximum target at the functional age. The higher the functional age, the higher the target. It's usually never 0.56, because then we will be talking about patients aged 60 or more. Hyperopia, low hyperopia, the Presbyond does the opposite. High hyperopia, well, it's the technique does it the same. So the softwares are prepared to do that. So again, the maximum threshold depends on the functional age. The changes rarely do they go over this 0.47, 0.50 microns. So whatever you do, probably you want to get above that. Here, risk patients, emetropia patients. In this case, the dominant eye we don't treat, non-dominant eye we do emetropia Presbyond treatment. We need residuals that are high because we won't do many aberrometric changes. And the ideal patient is in this range, 150 plus 3, hyperopia. You don't need to do the contact lens test. Here, the residuals need is lower, never more than 125. I think it's not necessary. So epithelial thickness, very important. Sometimes we think that what matters is the keratometric change. No, we need thin epithelia to elevate the cornea, to have otherwise we don't want epithelitis. The epithelium really matters more than the change in the curvature. The change in the epithelium is what causes epithelitis, poor vision, problems. The epithelial remodeling in some cases creates this multifocality. So this remodeling, this change, creates this because the epithelia, we need to not forget about the stroma, epithelium and stroma. This refraction difference between the epithelium and the stroma, there's this little multifocality when there's an epithelial remodeling that favors this possibility of the presbyopia treatment. It's important, the centering. You need to center well, because the kappa angle is high. This ablation in the coaxial angle of the side of the vision, we don't want to change the monofocality of the cornea. I have this norm. It's not just the eye, but I leave more myopic defocus depending on the functional age, requirements of the patient, the anterior chambers, the high densitometry, when I know there will be slight changes in the aberration, low keratometries, and low metropy, because then I have more, there will be more myopic requirements. The tolerance has its limits, but the patient needs to know that maybe it'll take a while longer. And in myopia cases, more myopic defocus. That's my norm, because they will need more time, because the aberration changes are different. A clinical case, so that's clear. Patient 48, operated 10 years ago, myopia. That was the myopia on which we intervened. 2015, normal case. Biomechanics operated on. 2025. He comes with these parameters, little astigmatism, vertical, 0.6, vision. He didn't want to wear glasses anymore. We did a test for contact lenses because there was emetropia. Good tolerance, apparently normal. So, 2025, we did a test. We performed a COVIS to see whether the post-LASIK biomechanics was good. PNS was 1, no cataract, no nothing. So that's why, age 48, we went for Presby LASIK. Left eye, good centering, nothing changes even after the LASIK, but the centering is really key. And then here, epithelium, remember, to avoid the apex syndrome. Treatment planning based on the functional age, reflection, optical zone selection, and the aberrations. What do we do here in this case? The system works with Malacara, and that changes a bit because it's the opposite. Plus 0.4, then it's minus 0.20 in OSA, so it's different and it's not very clear. We need to get used to that. So, right eye, I did nothing. Remember the age, functional age, well, I left it the same. Vertical astigmatism would help us for the near sight. I didn't program that. I only programmed the minus 0.20 myopia, and I left this astigmatism because that would be helpful for near sight. So I didn't program this astigmatism and aberration. So you see the different parameters. Plus 0.20 in cornea, little trick because the software allows to customize things. So I lowered a bit the aberration so that the effect was less of the aberration because I didn't want so many aberromatic changes with the negative astigmatism. I could play with, you can play with the aberrations to do a little bit more here, less here with the software, so to determine the defocus that you want to leave. In this case, same functional age, I could have changed that, but I didn't, and minus 0.82. I changed the aberrations because of the vertical aberrations, and that's what we did. Rather than raising the flap, we did a circle only of the first part, not to lift the flap, so to avoid epithelialization. A bit more internal vis-a-vis the anterior. It was just one diopter, so I had room. With more diopters, probably I would have needed more optical zone. That's a cut that I performed on a previous flap with a circle. Only one part of the circle because the rest I have cancelled. That's the way it looks. A little rim here, a little edge that looks so much better. That's the program and the difference between one cut and the other, and the result. Minus 125, 50, 90, 1. And the patient was so happy. Conclusion, these are techniques that you need to think about, work well with them. You need to master the laser. Whatever platform you use, you need to master. It's so versatile that you can play around with the aberrations and with the defocus. You can play with the defocus and use it as you want. And if you can do a circle, I prefer that rather than lifting the tapetum because it's important. The docking is important. And these techniques, all in all, it involves also the hands of the surgeon. Some personal arts and skills are involved here. Thank you.